Okay, be good up there. Josh.
Hey, Mike, this is Ashley. It looks like you have a quorum. So I guess whenever you and Janine are ready.
You guys all set?
Hi, Mike. Yes, I'm ready when you are.
Okay, go ahead. Okay, welcome everyone to 2021. This is our first committee hearing, and I believe it is. Let me see here. Yeah, this is our first one of the year. I want to welcome new members, Council President Jones and Councilwoman Simon, and like to thank our previous council people, and I believe Nan Baker's here, and Council President Brady for all the hard work, as the new members will find out, as I'm sure they're aware, that we deal with some hot budget ideas and concerns and questions, and we look forward to addressing the needs of the safety services and the justice affairs throughout Cuyahoga County and the citizens that we represent. Roll call, please.
Calling the roll, Mr. Gallagher,
Here.
Ms. Conwell,
Present.
Mr. Tillman,
Here.
Mr. Jones. Let's see, Mr. Jones
Here.
here. Ms. Simon.
Here.
There's a quorum. Also like the record to reflect that council members Miller and Baker are in attendance.
Welcome, council members Miller and Baker. And as usual, if everyone would please mute their computer or their device, it helps with the streaming and the understanding. And I'll try and make sure that I look to see if anybody is communicating that they want to talk. And if you do want to talk and I don't see you, please jump in there and let me know, and we'll have an orderly discussion. We'll follow the agenda as it's listed. So if we could, is there public comment?
No, Mr. Chair, no one submitted public comment.
In the packet you've received, committee members, you've received the minutes of our December 15th meeting. If they're in order, I'll accept a motion and a second.
So move, Conwell.
Is there a second? I'll second.
Second
that.
Jones.
All in favor?
Aye.
Against? Thank you very much. Resolution 2021-0027.
Resolution number 2021-0027, authorizing an amendment to contract number CE 1600252 with Applewood Centers for multisystemic therapy problem sexual behavior services for adjudicated youth for the period 7/1/2016 through 6/30/2020 to extend the time period to 6/30/2021 and for additional funds in the amount not to exceed $600,000.
We have someone from the juvenile court.
Yes, this is Sarah Baker from Juvenile Court.
Sarah?
So we are, hi,
Welcome.
how are you today?
Welcome, good, thank you. What say you on this?
So we are looking to amend our contract with Applewood Centers Incorporated for our MST program. This is run through a targeted reclaim grant that we have. And I've also invited our Deputy Director of Programming, Bridget Gibbons, to kind of give a little bit of data and background on this program, in case you guys have any questions on that. In regards to, we are well aware that the timing on this is late, quite late. So the reasoning for that is based upon just kind of countless, we keep hitting a wall in regards to different issues in the Infor system. So it is late, yes, but we're still asking for it to move forward through the end of June of this year. And then Bridget, if you want to kind of talk about any sort of data or background on this program.
Sure. So our multisystemic therapy program provides intensive in-home treatment to kids that are at the attention of the court, either pre-adjudicated or in this case, these are all adjudicated youth. We serve all felony level offenders. We have two different programs for multisystemic therapy. One is our more traditional model. The other one that we have is multisystemic therapy, problem sexual behavior. So they do intensive family treatment for kids adjudicated with sex offenses. It's the most comprehensive in-home treatment that you can receive. We have a good success rate with this program. This program allows us to divert children from being placed out of the home in expensive residential facilities or in community correctional facilities or Ohio Department of Youth Services. In the last year, we had nearly a 90% success rate with this program. And what that means when a child completes it at successful closing, it means that they're engaged or enrolled in a vocational program or a traditional education program. They're still living in the home with no new charges while in treatment. Then we take a look 12 months out to see how those kids are doing and how they're faring and if any of them have been replaced in out-of-home programs. Our biggest goal with this program is to keep them out of DYS. And we met 80% of all youth that were participated in the program have not been placed in a community correctional facility or ODYS. The therapists for this program are on call 24/7. They go out to the home for any crisis. They support families through domestic disturbances with their child with mental health issues. They go to court, they go into schools. They're on call 24/7. They carry a smaller caseload so that they can adapt to the family's needs. And it's our evidence-based treatment it serves the largest numbers in our juvenile court for family-centered treatment. They also serve substance abuse, other mental health disorders, along with problem sexual behavior and traditional, juvenile justice behaviors. And they target mostly the caregivers and supporting the caregivers to have tools to manage their child going forward.
Thank you, Bridget. Anything further from juvenile court?
I have a question.
Just a moment. Anything further from the juvenile court?
No,
No, I
we
don't
can
believe
respond.
so.
Okay. Ms. Conwell.
Through the chair, how long does a child stay in the MST program or the MST therapy?
It's a great question. So the targeted length of stay is 120 days. That is for the traditional MST track, which we just refer to as MST. Once we get into MST problem sexual behavior, the average length of stay is between 150 to 180 days.
Okay.
It can sometimes go longer.
And what was the cost? Because I see this contract is to add additional funds as well as extend the time period. What was the overall contract amount prior?
Sarah, do you have that in front of you?
I'm pulling it up right now. I'm pretty sure it was quite similar, but just want to make sure we have the right information.
Yeah, so that's what I was getting to. The amount prior, is this an addition because we have more cases or an addition because we're adding the time period length?
So last term we did add an additional 550,000.
Okay, so this one is for 6.
Correct.
Okay, so you needed a little bit more than 550.
Yes.
Okay, and is that because we're extending the time period to cover the time period or to cover additional cases we may have?
It's more so to cover any additional cases. The budget has always run fairly tight with this project. So we figured we would do the $600,000 this year, so we're not, worried about taking it too close this year.
Okay, and one final question, Mr. Chair. How many children do we have right now going through this on our rolls? What's the average per year?
Right. So we try to target a minimum of 60 youth per year for this program. Right now, currently in the program, I think that we have 25 youth, which would be about right. And this program is cost effective when we divert kids away from residential treatment. We're looking at around $9,900 per case versus a residential that can be anywhere from $30,000 to $50,000 per youth.
Yes, and finding the homes is another thing. Thank you. Thank you,
Yeah.
Mr. President.
Further questions from the committee? Anyone else have any questions? Hearing none. I would anticipate, because of the lateness of this, you would like us to move on this judiciously.
Yes, please.
Anyone have a problem with that? And ladies, I wouldn't concern myself with the lateness. We've become used to that, but I understand the difficulties with the COVID situation and some other things that you deal with that are unique to you and sometimes not others. We understand that, so there's no need for apology. If everything's in order, I'll accept a motion for resolution 2021-0027 to the full council under suspension of the rules. Do I have a second?
So moved, Conwell.
Okay, moved and seconded. Is there any further discussion? Hearing none, all in favor? Aye.
Aye.
Against? Thank you, ladies.
Thank you.
Thank you very much.
Bye-bye now. Resolution 2021-0028.
Resolution number 2021-0028, authorizing, authorizing an amendment to contract number CE 1600133 with Axon Enterprise Incorporated, formerly known as Taser International Incorporated, for Taser body cameras for the period 7/1/2016 through 12/31/2023, to extend the time period to 12/31/2025, to change the scope of services effective 4/1/2021, and for additional funds in the amount not to exceed $1,604,401.46.
Who's here to speak for the administration?
Even with the sheriff's department here, this is an amendment to our current contract that provides tasers and body cameras for the entire sheriff's department. The reason for this amendment is to add additional body cameras to cover more of our deputies.
You're speaking of the proposed substitute. There's a proposed substitute.
Oh, yes. So the substitute changes the end date listed on the agenda to 3/31/2026.
Is there somebody available from legal on this?
Mr. Chairman, this is Greg Huth.
You want to explain, and Greg, let's start the year under the right circumstances and a better move forward. I don't mind substitutes. I understand that. It's become the norm rather than the exception. I would expect going forward that the less we have to deal with substitutes, the better. If the legislation isn't done properly, hold on to it. Do it properly. This just has a tendency to gum up the works. We have our agenda and then we have a substitute that we have to bring you in to explain it, which is fine. Could you explain to me why we're going to 2026, how this came about, and under whose guidance are we following?
Mr. Chairman, as far as I can see, it's just changing the date. I don't think that's came through our office, so I'm assuming all it does is extend the contract.
No, do you mind if I have this on, or you want me to go in another room?
Mr. Nanny, could you mute? Go ahead, Greg.
So, Mr. Chairman, I think that explanation needs to come from the department.
So you didn't have hands-on?
Mr. Chairman, not on this one. No, the next one's my fault, but not this one.
Oh, well, I don't want to really spread out fault. I just want to point out that we would like to have it, you know, a little bit more in line with normal business. If you did not have hands on this, could I speak to who submitted the proposed substitute? Is there somebody in the sheriff's office that did this?
He went with the sheriff's department. So I had caught at the last second that we had submitted the wrong dates in our information that we had put forward for the board, for council. Because we caught it at the last second that the end date for this contract actually was 3/31/2026. But that coincides with the payment period of, we submit payment in April of every year. So it's just, the date change is just to capture that we get a full 12 months out of our funding.
So if I understand it correctly, we have a contract to 23 and you want to tack on to 26. Is that correct?
Yes, it is.
The concern that jumped out at me, and I'll have to see what the committee thinks, is that normally we don't do any more than a 3-year contract. Is there anything special within the boundaries of this request that would circumvent a 3-year extension?
Well, the program offered by this vendor that encompasses the body cameras, the tasers, the cloud storage, and the easy access website for our camera footage is part of a 5-year program. So any changes to that requires them to provide a new 5-year contract that supersedes the current.
And would this encompass all personnel to have cameras, and the upgraded taser, I would imagine, would be with the deputies? Would that encompass?
Councilman Gallagher, Captain Jerome, the body cameras would outfit all of our deputy sheriffs as well as our frontline supervisors, the sergeants, and then the tasers would outfit the entire department.
Thank you. Questions from the committee?
Councilman?
Yeah.
To the chair, to whoever can answer. In the contract, it states something that the project is funded from 100% from the general LE funds. I've never seen that LE terminology before. Can someone explain what that is?
I don't know why the information stated general LE funds. It is just the general fund, but the only funds that are changing within the contract really are focused on law enforcement, because that taser and body cameras are focusing on law enforcement.
So is that a typo? We need to take out that LE out of the resolution? Okay, and then my second question would be, you stated this extension or this contract, they'd like to have a 5-year period. Would this extension to 2026, this would take us outside of the 5 years, wouldn't it?
The current agreement ends, they're going based off of April of this year. So everything beyond April of this year is superseded by this amendment, which starts the new 5-year clock for that agreement.
And when will the next RFP be sent out? If we get locked in with 5 years from them, I think the way this is set up, it would actually, a year would carry over. Does that kind of lock us in where we can't do any new RFPs or RFQs, whichever one you did?
Well, this amendment came about because we were seeking those additional body cameras in the taser upgrade. and we were already locked into our current contract. So as this contract nears its completion, then we will go out for a new RFP, and we can look at what options are out there for tasers and body cameras, and whether or not they need to fall under the same company, or if somebody offers a better solution with body cameras.
Okay, and the RFP is for 2026. Is that what you're talking about? Because we have this addition.
Yes, that would be correct.
Okay. Thank you, Mr. President. Mr. Chair.
Any further questions or to the Sheriff's Department? Do you have any more input for us there?
Yes, Mr. Chair.
Mr. President, go ahead.
Thank you. You mentioned that there were enough tasers for the entire department. How many is that? How many in the department, and how many tasers are actually being purchased?
So, Mr. Jones, we're purchasing 215 tasers. Right now, we have, off the top of my head, I believe we have about 208 full-time sworn deputy sheriffs. And you always want to keep a couple in stock in case one is used. We usually replace that for the investigation, or if one breaks down, we ship it out and get a new one for them. So 215 is what we're asking for.
Is the same true for cameras as well?
No, the body cameras, we're only outfitting our deputy sheriffs and our sergeants, lieutenants, and command staff. I don't see a need for them right now. They would only be used for special events. We found that we captured the most footage from the deputies and the sergeants, so we didn't request additional cameras for command staff.
Okay. And did I hear you say you don't think there was a need for everyone to have a camera? What was the thought process behind that, as opposed to
just for example, for myself, being a captain, I'm not in the field all day long. I'm not engaging with the public all day long. So for me to have one, the only time I would be wearing it are for special events that I attend, just, like the protest or something like that. So that's the thought process behind that. Our deputy sheriffs and sergeants are on the front lines, and they capture the events as they're going on.
Okay, thank you. Thank you, Mr. Chair.
Any further questions?
Mr. Chairman,
Yes, sir.
my question is, what kind of situations are the tasers intended to be used in, and to what extent does their use cause injury?
Thank you, Mr. Miller. So the tasers are a less lethal option for us. An example would be to affect an arrest when verbal commands are not working and the arrestee is combative. I'm sorry, what was the second part of your question, sir?
The question is, to what extent does use of the tasers cause injury?
All right, so it does give a burst of electricity through the arrestee, usually after the couple seconds. After the arrest, the person is fine. We do get, in our policy, get them medical attention, whether it be having EMS respond to the scene or having them see our jail medical staff as soon as they arrive at the jail. But that's something our deputies are certified in first aid as well. So that's something they monitor if they do use these, that they get them medical attention right away if needed.
And final question, could you give me some indication of to what extent these tasers were used in 2020, and do we compile a report whenever they're used?
Yes, sir. Off the top of my head, I'd have to research and get you the exact number, but I don't think we've used or tased more than at least 10 subjects over the course of 2020. Every time our tasers are deployed, there is a use of force review done by the supervisor, also reviewed by myself to make sure that the deputy was in compliance with our policy. So again, I can get you the exact number, but off the top of my head, I would say we did deploy a taser more than 10 times in 2020.
Okay, that's helpful information. Thanks very much.
Anything further?
Yes, Mr. Chair. A couple more questions. The use of the tasers, are they used before or after handcuffs?
Before handcuffing, ma'am, it's to affect the arrest, so that you do not have to go hands-on with a combative person.
So that they could taser someone before they, okay.
Yes, ma'am, that's the less lethal option that we have.
All right, and training.
Training, we do our in-service training. We have sergeant or lieutenant, our certified instructors. And I might add with the Taser 7, they're offering training as well, which is virtual reality. They'll come down and do that for us. So not only we have in-service training, Axon will provide trainers for us as well.
Is that including the new trainees or old employees as well?
All of the employees, ma'am.
And how often do you do that? Train?
Our in-service training is once a year for all deputies. But we do have some scenario training that we do with some of our specialty units as well throughout the year.
Thank you.
Anything further?
But I don't know if you heard it. It is against our policy to tase somebody in handcuffs. So your question about handcuff tasing before or after, it's against our policy to tase someone in handcuffs.
Okay, just wanted to make sure. Thank you.
And that would follow common sense. I appreciate that. Hearing no further questions, I'll move the proposed substitute to resolution 2021-0028 to substitute the original legislation. Do I have a second?
Second for substitute, Simon.
Is there any further discussion regarding this item and this substitute? All in favor? Aye.
Aye.
Against? Thank you. Looking at the time, we have time, I would imagine, gentlemen, so we could do the 3 readings on this unless there is a concern that meets our standards of emergency. Hearing none, I would move resolution 2021-0028 for second reading as substituted for second reading. All in favor?
Aye.
Aye.
Against? Thank you.
Excuse me, Mr. Chair, I'm sorry. Who was the second on that one?
I thought, did I hear?
Funny.
Oh, thank you.
Did I hear, was it Simon?
Yes.
I apologize. I want to be sensitive to the time necessary for our guests from the medical community on the discussion portion A. So I'm going to hold 0001 till after they're done. I know that time is sensitive to all these folks, and I don't want to hold them up. So if everybody's okay, we can jump to discussion item A, which is the vaccine distribution schedule and procedures. Terry Allen, are you there?
Yes, Mr. Chairman, I'm here.
Okay, Terry, what I'm going to do is turn this over to you. I do, and for those of you wondering, this is Terry Allen, Cuyahoga County Board of Health Director. From what I understand, we have Dr. Watts and Mike Tobin from Metro Hospital, Sam Brown, Doctors Eric Becks, Sean Osborne, and Chris Miller from University Hospital, and Doctors Melissa Elning and Alice Kim from the Cleveland Clinic Foundation. If there's anyone new, Terry, I would ask you to take us through that. And if anyone is not available, we'll just move on without them. But we appreciate you being able to come here and help us out. It's a very confusing time, and it's a new situation for all. This is not a time to be, throwing stones and looking for problems. I think the concern that I have, and I believe other members of the council have, is that when we're dealing with seniors 80 and over, 75 and over, 70 over, even 65, it becomes confusing as to where they can go, when they should go, who they should sign up with. And the more information we get out into the general public, the better off we're going to be. I've actually read as much as I can about this regarding the rollout here in Cuyahoga County and the state of Ohio proper. And I got to tell you, I'm still confused a little bit. So if you can take us through this as best you can with our guests and help us get this information into the general public, and obviously any help that we can provide from our end, and I'm certain on the administration's end, we'd be here to help. So go, Terry, thanks for being here.
Thank you, Mr. Chairman and members of the committee. I'd like to start off by sharing my screen. If that's okay, Janine, I'll go ahead and do that to move forward, and we'll walk through a set of slides. I'm happy to be joined by colleagues from Metro Health, University Hospitals, and the Cleveland Clinic. We've been attached at the hip in many ways since the spring, regularly interacting throughout the pandemic response. And so I feel very fortunate to have such I think, a wealth of capacity in our medical community to work with public health. So I'll share my screen and we'll get rolling here. Great. Can everyone now see the slide set?
I can.
Yes.
Very good. Okay. So we wanted to first just note that we're really amid this transition point that, as the chairman points out, from playing defense around case investigation, contact tracing, cluster investigations, a whole range of this defense work we've been doing to try to combat the scope and magnitude of the pandemic to reduce death, reduce complications to the degree possible, working in concert with our clinical partners and social service community. And now we're moving into offense in distributing the vaccine. It's a pretty exciting time for all of us to know that we're turning a corner, but there's a lot of uncertainties as has been noted, and we'll kind of walk through some of the things and take you from here to there fairly quickly through this slide set. So we'll talk about the epidemiology, the basically the data supporting the work that we've been doing, how we've been tracking it, the community coordination that's taking place, the phased approach around vaccination for 1A, our healthcare workers, and 1B, our seniors and employees in schools, and some equity considerations as well. So this is a slide showing our epidemiologic curve. So we look at by date going back to last March. You'll see that we had an influx sort of mid-summer there, which now looks to be just a bump relative to what we've seen happen really since October here in Cuyahoga County. We saw a bump here occur in mid-June to mid-July. We saw the mask mandate put in place and saw a reduction. And then we saw this huge curve, which still continues. The message here is we track trends. We don't track a single week or a single day. All of us are tracking trends because there are fluctuations between data reporting that occurs and some delays and some lags. But you can see we are still amidst a major surge in Cuyahoga and certainly across the state of Ohio. These are data from the state website looking at our recent trends. So if you look here in terms of our case numbers, here's 1,000. And we've been trending countywide over 1,000 and fluctuating here and there in terms of our daily case reports, in terms of raw numbers. So still very high from going back in July, but gives you a more compact view of what we've been seeing lately. The gray box indicates that the data are still coming in and there may be some lag of data, and so that data are not finalized. If we look here, you'll see on the left, these are the case numbers for Cuyahoga County, countywide. 82,000 cases and over 82,000 cases, over 5,000 hospitalizations, and sadly we've had over 1,000 deaths in this community from many family members, friends, relatives, people we don't know have succumbed to this virus, and the many others have had severe complications. And so the scope and magnitude of the impact is immense. We all know that. We've lived it and we've experienced it ourselves. And thankfully, close to 68,000 people are presumed recovered. If we go to the next section, you'll see the series of boxes. The state publishes a public health, basically an advisory system to track what's happening around the state. And the latest report shows that we track cases occurring in non-congregate setting, that is outside of group settings, outpatient and hospital admissions, ED visits, and new cases. A range of data are tracked to determine what our position is comparative to other counties. And we are currently in red, the sort of the third level in the state's advisory system. And we're now running almost over six times this number circled in red, over 6 times the CDC, almost 7 times the CDC threshold for high transmission. So we're still seeing lots of case activity. We want to remind people that masking and social distancing and hand hygiene and staying home when you're sick and remote work are all things we want to continue to advise people to do. This is our countywide map, looking at cases by zip code. We know people move around a lot. Our data show that in our case investigation and contact tracing. They go to work, they move around and visit people. And we certainly know that interaction, that the diseases don't pay attention to borders. These data are compiled together with our partners at the Cleveland Department of Public Health. Here are some hospital data that we collect across all systems in Cuyahoga County from the Ohio Hospital Association. If we look at these data, you'll see that you have in blue the adult medical beds. In gray, you have these critical care beds or ICU beds, and you'll see that it's been fairly stable as of late, but we're still running at 82 and 80% respectively. You then come down here and see our yellow line is our ventilator use, and we track this very closely, and our medical partners can expound on this, and then the orange line is our pediatric medical beds. So we track these on a weekly basis and look for fluctuations, understand what the stress may be on the medical system, in collaboration with our partners who report this to the State Hospital Association. These data show our testing in coordination with our hospital systems. As you see here, going back to mid-December, early to mid-December, we had about 37,000 tests, and we were running about 21.4% of those tested positive. And so we saw a bit of a drop here during the holidays. No surprise, less people being tested during the holidays, some lag in test results. We're coming back up here from our data from the 9th, still showing about 1 in 5 people that are tested are positive. So lots of COVID still spreading in the community, lots of risk. And concerningly, we're still seeing almost 20% of people down here in our nursing homes that are positive from data from the federal government. So those are important, and speak to the work that's been going on with the pharmacy partners that have been vaccinating in our long-term care agencies. We know that's a priority. So we've been coordinating across all these sectors and more, certainly across public health and medicine, social services, our paramedics, and sorry for the typo, EMS, schools, elected officials, the faith community, academia. We also have been working with some community health workers that have helped us understand what's happening. We have a group internally looking at equity issues and messaging, and relative to testing and relative to our work going forward with vaccination. And I'll talk about that in a moment. So this is the overall phased approach that the state has adapted, and the 88 counties across Ohio are following this phased approach. We are still very much in this phase 1 point where we're having very limited vaccine. So this is a challenge as we look at phase 1, the 1A, and we'll talk about that in a moment, and the 1B. But that means that the demand far outweighs the supply. And then in the coming weeks, that appears to be the case. It will remain the same. We had heard some news that we originally had thought that there were doses held back at the federal level that would be made available to us to assist. But it appears now that those doses do not exist, that they've already been put out into circulation, and that we're then getting mostly our doses off the production line at the moment. You'll see then over time, as we move perhaps into the late spring and summer, we'll see vaccine more widely available, and into the fall, very, very widely available vaccine, and move through stepwise based on the phases that the state has outlined. So here's phase 1A. Public health is still very much working in phase 1A, dealing with a range of people in congregate facilities like nursing homes and faith-based congregate facilities, assisted living facilities that were not covered by pharmacies. We are working with the DD board, and we know that they have 480 facilities countywide where there are adult care homes or facilities serving those who are developmentally disabled. That's a huge number. And so we've been working through with the team to do vaccinations with our medical director, a team to visit those that are not mobile. And there are often issues around the ability of residents to wear masks or even caregivers. So we have to take special precautions in that work, but we are moving methodically through those facilities and looking at places where we can vaccinate those that are mobile in our points of dispensing and our pods. We've been doing clinics. We had one at Euclid this weekend at an e-check. We've been doing what we call points of dispensing or pods at the fairgrounds. We can do about 1,000 people a day at the fairgrounds. And we're going to be ramping up our vaccination, continuing to ramp up our vaccination process as vaccine is available. For 1A, we've been doing our EMS responders, as well as a range of hospital, healthcare providers who aren't connected to the hospitals. And in our community, it's estimated about 20% of our workforce is healthcare. So this is an immense amount of people. We estimate we still have over 10,000 people in 1A that would be eligible for vaccination. So lots of work to go, even as we begin to move into the 1B phase. And so now you heard over the late last week that there are now doses being split between statewide as they come in, split between 1A and 1B. So these are adults over age 65, as when those living in those with severe congenital developmental issues, and also adults who work in schools. It's estimated that for the 2019 census that there are about 230,000 adults in Cuyahoga County over age 65. And from our surveys working with the Educational Services Center, we estimate about 22,000 adults working in schools. So these are not small numbers, in addition to the 1A work that we're doing. So there is the problem with the supply and demand, particularly in the urban counties around the state that we're currently facing. So what's happened, let me go back one moment and say that right now we released data in coordination with the state, and we put it on our website in text form to work through now the first, and we'll talk about the phases in a moment of 1B, but to work through letting people know where they can go, their phone numbers, and where applicable websites for 81 locations across the county where those over 80 right now can receive the vaccine. So that's a lot of places, but the vaccine is spread out fairly widely, 15,000 doses in the county. So again, the demand and supply conundrum is still something we'll be dealing with for some time to come going forward. We know that the schools, if the governor's encouraged them to go either hybrid or full face-to-face by March 1st, and in order to get vaccine, they must commit to that. And so we've been working with our schools weekly to work through that process and how we can scope vaccinations for them going forward. But it will take us well beyond that to vaccinate the full school community. So we're in this stage now where there's an overlap between phase 1A and 1B. And so that's a challenge we face, but I know that our role here at the health department is to continue in earnest with 1A, even as our 81 partners are working hard on 1B vaccinations to begin that process, because we don't want to leave behind the DD board folks and a range of other providers that still need to be vaccinated and healthcare workers. So here is our strategy of approach. Our current reality is unlimited vaccine. We've got to think about how to use these resources, and that supply is being divided. In some cases, pharmacies may only get 100 or 200 doses. Certainly our hospital systems can talk about the doses they're getting. We're going to focus on 1A, and we've been working with Metro Health around a range of vulnerable populations from testing going forward. We thank Dr. Watts and Dr. Boutros and their team there that have been great to work with to help us reach those that may have challenges coming to us. The hospitals are focusing on in 1A, vaccinating their employees, those forward-facing staff who are taking care of patients who may have COVID. And also they're focusing on their patient populations with 1B, along with the federally qualified health centers doing the same thing, and they're focusing on their patient populations for 1B. And then the pharmacies, those that come in to receive prescriptions, and they're also taking overflow, and there's lots of overflow in these situations. People calling wherever they think they can get the vaccine, people calling other counties. We want people to look close to home first. We appreciate some general work we're doing now with the Department of Senior Adult Services. In particular, Tracy Mason has been great. Her staff are helping senior centers, libraries, Western Reserve Area Agency on Aging, and we're going to be working with others going forward around trying to help seniors sign up. And Dr. Watts has some data in her early stages around seniors that she'll talk about shortly because they need more help with signing up, particularly those over 80. If we look at 1B, we know January 19th today, seniors over 80 are now qualified for vaccination. We then move on to the following week on the 25th and see that those 75 and older are qualified, and those with the severe congenital or developmental issues. And then on to February 1st, we include those over 70 and also the school employees. And then finally, February 8th, we have those over 65 and older. So it's a tiered process. We know we won't move through each of these weeks. We will not complete the 80-year-olds. When we move to the 25th, we won't complete the 75 and older, but we're moving stepwise. And the thought process is to give a chance for this, particularly at risk group, where we know the fatalities are highest and the risk for complications are highest in these groups, to give them a chance to get vaccinated, a chunk of them to get vaccinated in that week. And of course, it is the supply-demand issue. It's hard to stress the challenges that we face, not only here in Cuyahoga and Ohio, but across the country with this disconnect. So we have a range of places now, the 81 locations. We have pharmacies on our website, right on our homepage. As soon as you go to our homepage, you'll see a link that says, click on these for the providers there. And we've pushed that out through media channels and lots of places. And I think it seems to be, it still needs to be more widely spread, but it's getting out. The community health centers, as well as the hospitals and the health departments, reaching out to take care of these populations. Here is our website. On the homepage, you'll see this as soon as it comes up. It's under our revolving banner. It says, see the COVID vaccine provider list for those 65 and older. And then we have a link that you'll see that they can click on. And if you need that link there, it's there for your viewing later. We share that widely through circles so people know where to go to see that text list. Also, there's a link there to the statewide list, and we make sure that we're connected. Here is the statewide website with the vaccine locations, and you'll see there's a website as well, and this will provide you the locations in every county in Ohio. So we're working to assure that there's equitable distribution of the vaccine. It includes looking at a range of those living in Black and brown communities, those with underlying health conditions, sexual and gender minorities, people living with substance abuse or mental health challenges, immigrants, also refugee populations, people living with disabilities. We want to make sure that we're reaching east, west, and south, everywhere around the community, focusing on congregate sites and doing our best to not only assure that vaccine is available, but that people can make choices about getting the vaccine and understand the issues on the development of the vaccine, the FDA process on development. We know that people have concerns and there's some skepticism. There's some hesitancy, and we understand the history and why. And so we have an equity group here that's been working to address these issues. Michelle Shaw in our office has been leading that work. Two members of our board, Dr. Greg Hall, and an African-American man who has worked in nursing homes and talked recently in one of our briefings with Executive Budish, told his story about living with COVID. He was in the ICU for a week and he was in bad shape, and then talked about why he got the vaccine. And Dr. Sherry Williams, an African-American pulmonologist from Metro, talked about the cases she's seen and the devastation that COVID has wrought on families in her work at Metro Health, and also talked about why she got the vaccine. And we're going to be pushing those messages out and socializing those as best we can with some compact messages for the community. We also are looking at some strategies around equitable distribution. This was provided along with many of these slides in a webinar that the state did for all the providers. There are 1,700 providers now in the mix that are providing vaccine for 1B, the seniors right now across the state. And so you want to look at after hours opportunities, coordination with faith-based communities, and we're actually doing that and have worked with a number of faith-based communities around testing with Metro, and we'll continue to do that for vaccination. Transportation opportunities, and our friends at the county in DSAS and the range of social service supports are supporting that. Also looking at mobile vaccination opportunities and looking at media across a range of sectors to provide some support and opportunity for people to know about where to get vaccine and how. Ultimately, who's next? That will be based on, I think we're going to be in phase 1A and 1B for some time. It will be well into March and perhaps beyond before we're able to move on, given the 230,000 people above age 65 and 22,000 people working in schools. So that's a huge chunk of folks in addition to 1A. So we're going to be working with the state on the guidance from CDC on which groups to do next. And they have not yet announced the groups that will be next, but we'll wait to see what they have to say. And we've been coordinating very closely with our hospital systems and will continue to around how to best message and address this very large group right now, even as we think about what may come next. So I just want to thank lots of people that have been part of the process: emergency management, the Medical Reserve Corps, community emergency response teams that are helping us, the EMS partners. We've been working with David Merriman, coordinating a social service group that's been working with the county for quite some time, working with that group to help us understand how to best serve the range of vulnerable populations, school districts, our clinical community, and of course my folks, 160 of us, but they've been working 7 days a week, many around the clock, and it's hard for me to express how much I appreciate what they've done and continue to do in this extraordinary time. So with that, Mr. Chairman, I'll stop, and if you'd like us to proceed, we can, and I can turn things over to Dr. Watts if you'd like.
I think that would be best.
Yes, sir. Okay.
Well, thank you. And thank you, Mr. Chairman. And thank you to Terry Allen for his leadership through this difficult time. I have to take a moment because I'm not sure that maybe it came through, but Terry's teams have been working on vaccinating in the homes for the developmentally disabled, starting really over Christmas week. And given how vulnerable these populations are and how much suffering we've seen in those environments, I just must say, from sort of as a partnership and as outside looking in as a community member, I think it's one of the most incredible gifts and blessings that I've seen in the last few months. So really a light, bright of hope in a time that's been awfully dark. At Metro Health, we've been pleased to be part of the community response from the beginning with our hospital partners and with public health. Thus far, we've fielded more than 70,000 phone calls on our free Dr. COVID line. About half of those have resulted in clinician visits, all done through telehealth, which helps us to keep folks who are concerned about being sick home and out of the community where they can potentially spread. Working with our public health partners, we've also done testing, as many of you are aware, in multiple congregate living environments, particularly the homeless shelters where we are on a regular basis. We've completed thousands of tests at this point, and we're really pleased with the effects of those partnerships, which we think have really helped to mitigate some of the worst parts of the community spread. We have begun vaccinating our employees in mid-December when we got our first dose of Pfizer, and we have begun with patients starting this weekend over Martin Luther King Day. We are focused at this point on our vulnerable seniors. We hope to complete about between 2,000 and 3,000 vaccinations for our vulnerable seniors this week. The number one barrier that we have at this point are twofold. Number one, as Terry alluded, we have found that our seniors do need more support to get appointments scheduled than was true for example, employee groups. It appears that about 20% of our seniors are able to manage a fully automated process. This means that on our part, we're doing a lot of outreach, phone calls, getting a hold of the daughter, trying to help people get right transportation in for a visit. But we've seen a great, robust response with that type of outreach and really facilitated scheduling. The second barrier we're facing right now is lack of vaccine. As Terry alluded to, we simply do not have enough vaccine in this community right now for everyone who is deserving or who is vulnerable, who really should be at the first of the line. There are lots and lots of people who should be at the first of the line. So I think our plea from all the hospital systems, and I know we share this, is we are ready and willing to get the vaccine in arms as quickly as we can get it, but we just don't have enough vaccine right now. So I think I'll pause there from Metro Health, and perhaps I'll pass it on to my next hospital partner. Somebody's got to pick up the ball.
Oh, sorry, I'm trying to get off mute as the whole virtual era. So Alice Kim from Cleveland Clinic. I'm actually helping Dr. Weiler with Zone 1 COVID efforts for the past year. I just want to reiterate Terry Allen and his group's efforts. It's been more than extraordinary, and we could not do what we've been doing for the community without them. So thank you, Terry. Again, effortless work nonstop. I also want to say that all of our hospital partners have really come together to make it a collaborative and as coordinated an effort as we can. Again, the rate limiting step is really the supply chain. Again, we were all caught off guard when the stockpile was not there as we had expected. So again, as we are receiving supply, we can definitely ramp up and get to the community as we need to. But we are just hoping that we can get the message across to the community that we will get to you. Patience is really what we need right now. We are trying to get the most vulnerable, high-risk patients as we move through the prioritization platform and process. So again, I think what we're trying to do as hospital systems is reach out to our own patients, which we all have on either our electronic health record form or through text or telephone calls. And as you become eligible, which will mean that you have reached that criteria, we will schedule you as we get the supply in. So again, I'm trying to get the messaging that eligibility does not mean that you will get that vaccine today or tomorrow. Eligibility means that we have you on note, we notice you, we know that you exist. And when we get the supply in, we will notify you directly to come and schedule. So again, the clinic has multiple sites up. We have 5 sites within the community, again, ready to rev up as much as we can when the supply comes in. But again, it is a coordinated effort. And again, thank all my hospital partners who have been working with us, not only on this effort, but testing, identification, and all the education that has been going through for the last year.
All right. Good afternoon, everybody. Sam Brown.
Lost you, Sam.
Can you hear me now?
Here we go.
All right. Sam Brown from University Hospitals. Don't have much more to add other than the debt of gratitude to all the folks that are working in this space and have been working tirelessly since last year at this time to prepare and respond. From a health system standpoint, we're in the same boat. We've vaccinated as many employees as possible and caregivers. We've started our vaccination clinics for the public, and really the biggest rate limiter is going to be vaccine itself. We've got immense capacity amongst the health systems and public health in the county. It's all a matter of getting inventory into the market that allows us to then vaccinate folks as quickly as possible. But also want to take one last moment to thank all of you on the phone. I can't tell you how much it means to our caregivers, for the folks that have supported all the frontline caregivers throughout the community. These folks are working tirelessly day in and day out to take care of folks that are sick and to prevent illness, and very much appreciative of everybody's support. However big or small, certainly it's much appreciated by myself and all of our colleagues. Thank you.
Mr. Chairman, I think that we've heard from the three systems I wanted to provide sort of the big picture overview. Thank you very much to Dr. Kim, to Dr. Watts, to Sam, and the support from everyone, knowing that we have great uncertainty. And they've been happy warriors working through this process because the vaccination stage is exciting for everyone. But anything we can do, we've been working hard to manage expectations, which we know are immense right now. Our call centers have been overwhelmed with calls from seniors who understandably are interested in vaccination. So, Mr. Chairman, we'll hand it back to you.
Terry, and thank you very much, and doctors and Mr. Brown, thank you so very much. What little time we spent here has cleared a lot up for me, and supply seems to be the devil in the details right now. Is there any indication whatsoever from the feds as to when this is going to loosen up, or are we just dancing day to day?
Mr. Chairman, I heard from this morning, we do a call every Monday morning about 7 o'clock with the governor of the health departments. So since way back when this all started. And he always asks us where are the problems, and he tells us kind of the lay of the land. And his understanding is that in the coming weeks, we wouldn't expect to see much of a difference in vaccine flow, at least in the near term over the next few weeks. We certainly hope that that is the case. Beyond that we start to see an increase. We know that right now we had all hoped, as Dr. Kim noted, that we would have seen that stockpile available, but it was a letdown for all of us. We had hoped to be able to access that vaccine. But right now, our allocation is splitting 1A and 1B. And that's a reality we're going to face as we try to reach lots of folks who justifiably should be vaccinated in this difficult time. So 15,000 doses came this week for that purpose for 1B. And, that's not a lot in a county as big as ours, but we're going to continue to move through stepwise and do the best that we can to make sure, as Dr. Watts likes to say, that it doesn't do any good in the freezer. We need to get it in arm. And I think that that's the way we're approaching this work.
Right. And has there been a targeted campaign, at least with mailings, or has this just all been website and media driven?
The locations that we were provided through the state, I know that the state interfaced with all of the providers, these 1,700 providers across Ohio. And the website information currently has a phone number, and in some cases a website where they can log on to provide registration. I know each of our call center, we get lots of calls, lots and lots of calls every day. We've been on the order of as high as 1,000 calls a day, but usually hovering in this 500-600 call day range since the beginning of this, but it's increased with the vaccination stage. And each of the individual systems have their own processes, and I will defer to them to describe their processes, Mr. Chairman.
So what I'm hearing is really not any mailing campaign. Knowing seniors, as I think I know seniors, is they're very comfortable with things that come in the mail. They're very uncomfortable with modern technology. And that you can even consider that a cell phone. And I'm wondering if there's something that we could do on our end with the administration to target folks 65 and older, understanding that we're probably looking into March to take care of all of this. But if they have something in hand on their kitchen table, I can assure you that they're more comfortable knowing that they have something that could tell them what number they should call or where they can sign up, as opposed to just hearing it. Many of the senior centers are shut down or at low capacity, and that would have been a great place to go. At least in my community, that certainly would have been the place I would have started. But I'll talk with the administration about that. Questions from the committee? Anyone not on the committee?
Thank you, Chair. I didn't want to ask.
Yes, ma'am.
Thank you. Thank you for allowing me to join your committee today. certainly have been following the cases from the beginning, and thank you, all of you, for all that you've done. It has been a very trying time. I guess my concern that I really love talking about the vaccine and not so much the cases anymore. It's really all about getting people vaccinated and back to their lives again. I know it's concerning that we don't have the supply, and up until the end of December, we didn't even know we were going to have this vaccine on time. Typically, it's 5 to 8 years for a vaccine to be approved. So to have it this early is just unbelievable and remarkable. So as it's coming out slowly, I know these vaccine carrier manufacturers are working hard to push this vaccine out. AstraZeneca and J&J are working now close to approval to have a one-shot dosage, and the refrigeration is much less. Also, the Moderna and Pfizer are talking about putting, plus billion of the vaccines out this year. So why is it that we are hesitant in thinking that once we get through February, maybe 1st of March, that we won't have hundreds of thousands of vaccines available? And I guess I will tag that with a question: are we ready for that? I mean, if you're talking about vaccinating all of Cuyahoga County and focusing on 65 or over that are 230,000 people, do we really need to register and get in line and wait for the call? Is there a way that we can do it in a more massive drive-through? Here's your vaccine, come back, or maybe not come back if it's a one shot. Are we prepared when those vaccines do come in an amount where we're not worried anymore about having a shortage?
Thank you, Councilwoman Baker, for your question. I'll start off, and I would very much be interested in hearing from our hospital partners as well. We've been talking right along, and as you say, we don't want to make sure people know that we're not out of the woods yet on the cases. And there is a new variant strain from the UK that we know has emerged as more infectious, and so we're watching that very closely. It will soon be the dominant strain in March, they think, in the United States. So there's still a lot of work to do on case investigation and vigilance. We have been, back in 2009, we did H1N1 vaccinations and had our pods or points of dispensing and could vaccinate 5,000 people a day in a point of dispensing using for H1N1 vaccinations for the influenza vaccine at the time for that pandemic response. What we've adjusted here is because of the fact that we're amid a surge, is we have been using drive-throughs at the county fairgrounds. 1,000 people a day, 4 to 5 minutes per car, 2 shifts of 35 people, vaccinators, people drawing up vaccine, medical monitoring post-vaccination, registration, traffic control, a whole range of inputting data into the state system. We also know that there are places, if you have a large enough footprint, that you can do it inside and space out. Some folks have done that, and I know the clinical setting, they've done that as well. So the idea is that, can we, where we have a larger percentage of the population vaccinated using that H1N1 model, can we use, gyms and other places where we can vaccinate at that level? Right now, I go back and look at the old H1N1 pictures, and everybody is right next to each other, elbow to elbow. And our concern is that proximity, and can we do that effectively with personal protection to ramp up into the summer in a situation along those lines if more of the population are vaccinated? Or can we use the outdoor setting, which we now we've started doing drive-throughs for back to school vaccinations last August, and then flu vaccinations in September, adapting our model from H1N1. So we think we can ramp up. We've been through the Ohio response system. We've been getting volunteers that are coming forward, and I appreciate County Emergency Management, Brandy Carney's group, that have been working with us to help us organize medical and non-medical volunteers. And so I think we have the ability to ramp up. but we also have incredible capacity from our health systems and incredible partnerships. And so I would also know that they'll want to share their thoughts as well to your question, Councilwoman.
Yeah, this is, I'll talk on behalf of the Cleveland Clinic. If the supply was unlimited, we do have the capacity to ramp up to 7,000 plus vaccinations at multiple sites that we have stood up. So the issue about why, the supply issue, I think is really the barrier right now. The registration needs to happen and be thoughtful of that because it's under emergency use authorization. So there still is a need to monitor and track and trace who these patients are, not only for the second dose for the Pfizer Moderna, but just to make sure that the adverse events, as these vaccines are pushed out earlier than expected, are recorded. So I think the hospital systems, and I know UH has huge capacity as well, because we are all working together to see how we can support our the hospital systems on themselves, but also support the community at whole with Terry's and public health. Because that's the only way we're going to get through it. So to answer your direct question, we do have the capacity. We're already planning on that as we are anticipating, hopefully, that we'll have more different products pushed out. But again, we don't know the manufacturing process nor the distribution. And this, again, that supply chain issue is something that I think people are still trying to grasp on how that's going to affect us in the future. We just know that, and we are all hoping that we do have what we need to do in the next few months.
I'm sorry, Chair.
Yeah,
I got blocked out. So I missed some of that. I apologize. It's technology, not at its best. If I may follow, I'm not sure. I don't want to interrupt anyone. Is this a good time to follow or no?
Go ahead.
Is it all right? I guess my question was, and I heard most of Dr. Allen's response, but if we were to ramp up, if we were to have the vaccines in place, and I heard him say the H1N1 and 1,000 a day, that's 7,000 a week. We're still talking hundreds of thousands of people though. Do we have the personnel? Do we have the coordination? Are we ready? Do we have a master plan beyond the registering and all that we're doing now because supplies are so limited and we're trying to reach the most vulnerable? Do we have, if someone were to ask you, what is your master plan if March 1st, you will have all the vaccinations you want, what would you tell us your plan is?
I don't know if you missed my point from the Cleveland Clinic. We are already working towards if we had unlimited supply. So at this point, we have staffing up to doing 7,000 plus vaccinations a day within our health system. And again, I know Sam Brown can comment on UH because we are both all watching and collaborating with each other to make sure that the sites are geographically placed so we can, again, have a spread not within our hospital system, but within the whole region. So those are sort of strategic. And again, the partnership, I have to say, has been really exceptional. Go ahead, Sam.
I did not hear that.
From the UH perspective, similar story. We've got the almost spot on capacity that is geographically disparate from the clinics. And that's intentional in order to make sure that we can hit the community closest to home. We do collaborate, and I cannot stress this enough. Since the beginning of this, the collaboration amongst public health, our emergency management folks, and the health systems has been beyond my wildest dreams personally. The level of engagement, the level of support, the creativity, and the spirit of work that's been done has been absolutely phenomenal to help address this. And I'd like to think that some of the effect of our community, while certainly it's been rather significant, a lot of the efforts have been very well thought through and coordinated in a very innovative fashion. And I'm very proud of what this community has done over the past 12 months. But we are ready to go. I think it's the moral of the story from the health system standpoint. We're coordinated. Of course, we'll learn along the way as we have throughout the entire pandemic. But we're ready to go. And frankly, if we were to receive max doses, we'd be flying away and vaccinating folks at a rapid scale.
Good. Thank you, Chair.
Mr. Chairman.
Yes, Mr. Miller.
Thank you. And the first question I have is one of scheduling. Can a person who's in 1B that's going to be eligible a couple weeks from now, can they go ahead and schedule an appointment for February or March, or do people have to wait until their eligibility date arises before they can do the scheduling?
Mr. Councilman Miller, through the chair, the issue, the conundrum we're facing, as you heard all of us share, is this issue of having adequate vaccine in order to make it happen. So what we do with our large pods, where we're doing 1,000 people a day right now through these are healthcare worker folks that we continue to vaccinate. We have to staff those up for 70 people in a whole range of roles. And then when we know we have the vaccine available, then we're drawing down from a list of people that have pre-registered. But we don't send out that pre-registration until we know we have the vaccine to do it. So that's part of the challenge to scope it out that far in advance. At least that's how public health has been working it through in terms of how we schedule. I will tell you that when we put out a link through our pre-registration list for the healthcare workers and allied professions, that will fill up 1,000 spots in 30 minutes. So the demand is just huge. And we will do that based on having that vaccine available to serve those folks. We don't want lots of people lining up to no avail. And I would defer to our hospital partners for other thoughts.
Mr. Miller, you have anything further?
Yes. I've been reading about how the new administration is talking about setting up these very large vaccination clinics at very large space facilities. Is this on your radar screen, and how do you plan to implement this if this comes to pass?
I believe, Councilman Miller, that some of the hospital systems have talked about their ability to ramp up. I personally think the way to look at this, in addition to having large clinics that we can ramp up as we have at the fairgrounds, we believe if we have more vaccinators, we can handle higher volumes, particularly if the weather's nicer. Right now, our folks are out 13 hours a day at those clinics with set up and tear down and long days in the cold, but they've been fantastic in that work with EMS, who has been there with us every step of the way, in all the communities stepping up to help us vaccinate. And so it will be a combination of these hospital systems ramping up their capacity across their enterprises, along with we would have our points of dispensing. These would be coordinated along with pharmacies that will have access to the vaccine. So you have lots of places right now, 81 places that have the capacity to distribute vaccine, so that it's more available, like seasonal flu vaccine in many places. I think that's the goal, is to have it available almost in every corner. I think that's one of the quickest ways, in addition to making people drive to you. It's even better if they just have to go around the corner.
And
I might add, can I add to that answer? By the way,
Mr. Executive, 1 second. I want to come to you and give you enough time to go through what you need to do. Mr. Miller, are you done?
Just one more question. Are we now anticipating that we're going to get an allocation of vaccine on a weekly basis, and that hopefully the amount received weekly is going to gradually start increasing? Is that what we're hoping for?
We have been seeing weekly allocations so far. In the near term, Councilman, we expect that to be fairly stable on what we've been seeing. For 1B, that's about 15,000 doses across Cuyahoga County, distributed across those 81 providers. And we think in the near term, it'll be relatively the same for the next few weeks. And then we hope that some indications are that it would begin to rise. But when that exactly happens, we don't really know at this stage.
Thank you, Mr. Chairman. I have no further questions.
Thank you. I have just one quick question. I want to bring in Mr. Budish. This is a question for Dr. Watts or Dr. Kim. The number of those that have recovered is 60 to 70,000. Would it be fair to place those on the vaccinated list to bump that number up a little bit? Because I personally have had this and I have recovered, thankfully, but I don't know, and I've not talked to my doctor yet, but I don't know if he's going to recommend that I get this vaccine at all. So should that number be a little bit higher? Not that it helps us out much, but it gets us to the goal of getting everybody inoculated.
Sure, it's an important question, and the CDC guidance has been very clear. If you are recovered from COVID, as long as you don't have any symptoms anymore, you are an eligible candidate for vaccination. It's pretty clear to us that folks, unfortunately, can get COVID more than once. And we all want to move towards a place where we can get back to our lives, which means getting as many people vaccinated as quickly as possible.
But I just want to put as a caveat. So with that is with limited supply, there is a clause that says you can wait 90 days from your COVID infection. So you can, again, boost the supply for those patients that have not had it, because we believe in the first 90 days, you do have a less chance of getting reinfected. So is that some of the strategy we should look at with limited supply? So I think these are all things we're sort of thinking about, but there is no contraindication for you to get a vaccine if you've already had COVID.
Okay, that actually helps a lot, and I think it helps 60 to 70,000 people out there. Mr. Executive, I know we piqued your interest with discussion on possibly involving the county in a mailer, but do you have anything further?
Yes, thank you, Mr. Chairman, and I have been listening attentively. I really think this is a very valuable public service. There is a lot of confusion out in the community, as you noted, and to be able to bring this kind of information out to the community is very, very helpful. So thank you for that. I wanted to thank the 3 hospitals that are represented here today. I can tell you, I will confirm that what you've heard, which is that the level of collaboration is something I haven't seen in ever. And this is tremendous. They came together, they've been working together for the good of the community, putting aside any competitive issues, and it's really been extremely beneficial to everybody, from testing to tracing and now vaccinating. And especially I want to thank Terry Allen and the Board of Health, because what they've been doing is if someday we can get all that information out as to what you've done, Terry, and what the Board of Health, I think it would be extremely eye-opening for the community. To respond to your issue, Councilman Gallagher, we are looking at, it is difficult for seniors to cope with websites and computer, get on the computer. And so we're looking at ways that we can be more helpful. I can't announce anything today, but I am planning to speak with President Jones in the next day or two about an idea that we've nurtured and worked through. So hopefully we'll have a response soon on that issue. And to Councilman Miller, I will say that, if you read in the papers, you can see what other places are doing. Everybody's got a little different approach to distributing the vaccine. I was just reading this weekend that in Los Angeles, they're using Dodger Stadium to distribute vaccines in a mass way. I've actually asked the same question that Councilman Miller asked today. I've asked the same question directly to the governor, because there is a difference in approaches that can be taken. Terry Allen's explanation is exactly what the governor stated, which is that getting it out widely, albeit in smaller venues and smaller amounts, makes it more convenient for people to get to a place near them to get vaccinated. It does make it harder because it's not one place everybody knows, but it's widely distributed. So right now, at least the governor has decided to spread the distribution as widely as possible. And that's the way we're going. We have discussed with other larger venues if they would be available, and we've gotten very positive responses. So if the governor changes his approach and we go a different direction, I think we'll be prepared for that also.
Thank you, sir. Is that it?
Mr. Chairman?
Mr. Jones.
Thank you, Councilman. We've heard the national narrative that the African-American community has been slow to want to take the vaccine. But my question to you is, here at the local level, and knowing that there is limited supply, have you seen a hesitancy in the African-American population to take the vaccine? And if so, what efforts have been made to try to overcome those challenges?
Thank you, Councilman Jones. I want to make a brief statement and then I actually would like to defer to Dr. Watts, who had, I think, a good story even this morning on some encouragement in that front. So what we've been doing through our equity group is to reach out through some community health workers to understand the barriers that you described. I think a lot of people we're hearing are more likely to accept the vaccine if they feel that a relative or someone else has gotten it, or perhaps encouraging them to do it, or someone they know that has gotten it, and that they heard that they haven't had problems with major issues with side effects, and they're more comfortable. So that we've heard a number of folks say in the African American community that they would consider it, but they don't necessarily want to be first. And so I think that we are working to decide what that messaging looks like. What can we do around assuring that we're answering all the questions people may have so that they can make the choices that they'd like to make based on the best information, and also looking to encourage through community leaders like leaders, African-American physicians and others. And I believe Metro Health has been working with the faith-based leaders to encourage vaccination and to mobilize our leaders to demonstrate to folks that the vaccine is safe, it's effective. And so those are a number of fronts that are in progress. There have been some work going on also with the foundations through the COVID Rapid Response Fund, where the local foundations are looking at community messaging as well, and have a group focused specifically on issues around equitable vaccine distribution and availability. And with that, I would turn it over to Dr. Watts for some new information that I thought was very exciting she mentioned.
Thank you. We're facing a real issue. We know that we need to make sure that communities of color have good information and can make educated decisions about getting this vaccine. We've been trying to do some very targeted efforts in partnership with the Board of Health and others, as Terry mentioned, especially leveraging faith leaders, both in a variety of different forums. But I must tell you, I am sitting in Cleveland Heights right now, where we're vaccinating hundreds of vulnerable elders. And I walked in this morning, and the waiting room, we started at 7 in the morning, and the waiting room was full of African American seniors, all that had lined up to get the vaccine. We have folks in their 90s. We've got a few over 100 that have come in from home today to get vaccinated. And I think for all of us, it's a great joy to see the willingness of communities that may have true reasons to be skeptical, stepping up and being willing to get this vaccine. I couldn't help but share that with Terry this morning. I wasn't the only one that was crying. So it was a joyous moment for all of us.
Well, thank you. I really appreciate that. Can you speak towards the nursing homes? How are the employees and the residents specifically, how are they being covered by the vaccine, and at what rate? And is there any hesitancy there?
Thank you, Councilman Jones. What we've heard, the statistics that have been shared is around 75 to 80% of residents in nursing homes are willing to be vaccinated, which is very positive, but we still are seeing hesitancy among workers. About 40% of workers, in some cases less, in the nursing homes have gotten vaccinated. Many of the workers are low-income folks. Remember, they are communities of color that often are serving in those roles. I remember during testing early on that we were doing in coordination with Metro Health and others, and our medical director, Dr. Gullett, out with teams, that folks were scared. They were very scared about the virus. And so they're on the front lines and likely to be exposed, but that hesitancy is existing. So it speaks to the need to continue to message and educate, but let people make informed decisions about vaccination. But yes, the vaccination rate among the nursing home staff is lower than the residents at this time.
Harry, what did you say the percentage was?
Councilman, and for the residents of nursing homes, it's 75 to 80% are getting vaccinated. And among staff in nursing homes, it's 40%. In some cases, it's a bit lower.
I wanted to add that we did have the opportunity to make a small video that some of you may have seen with some of our faith leaders who are older seniors in the faith community, including Reverend Otis Moss, who were able to come and get vaccinated and get vaccinated publicly and be taped so that those messages could be used, as truly trusted leaders to get out and really help us, especially with the younger populations, for example, the nursing home workers who are really looking just to make sure that they feel safe in getting this. And we know that the faith leaders can really help us in that way.
I agree. And I believe that raising that 40% is critical. The nursing home workers, that's an area just that needs to be addressed. And the challenges just need to be overcome. And I think it's done through education and through, as you said, trusted individuals, leadership within the community when they see them vaccinated and they get to see the success of it and that they're not harmed by it. I think that will open the floodgates, and we need to see that 40% number rise.
Anyone further?
One question, Chair, if you don't mind.
Yes, ma'am.
As we are vaccinating the nursing homes and congregate care and targeting those for very good reason, will we be tracking the number of vaccines that we have administered? And also, we are anticipating that the death rate will go down, and we will be also tracking that. And as vaccines keep, as they're administered throughout the community, will we be tracking and showing that the cases are lowering and lowering because of that initiative? That in itself could be an incentive for people who hadn't gotten it done yet to get it done. So in short, are vaccines being, I don't see that in I don't see that on the county report yet about how many vaccines are administered. And I don't see it on the state site either. And I would anticipate that the death rate would be dropping.
Thank you, Councilwoman Baker. On the state website, they do now include data for each county, the data on those vaccinated. So in our case, as we enter the data and as every vaccine provider enters the data, if they've been approved provider and they have vaccine, they're entering directly into the state immunization registry. And so they enter the data, and it is then sent to the state and onto CDC to track. This is how all vaccines are tracked in terms of doses given across the country for any vaccine. So you get your national immunization rates emerge from those data. So they have it broken down by age groups. We've begun also collecting data now. We've begun collecting race and ethnicity data so that we can track that as well. We think that's important. So, I mean, what you bring forward is what we are all very much hoping for. What I've been praying for, Councilwoman, is that we start to see a change in the fatality rate. We had a big surge of fatalities, and when I get these messages from Dr. Gilson's shop about the people that all the people that have died from this, it still shakes me every time I see those messages. So our hope is that we get to a stage where we have vaccination rates are rising, and the weather gets warmer, and perhaps we start seeing a dip in cases, and the vaccine availability becomes more plentiful, and more people get vaccinated, and we see a drop in fatality rates, and we see an ease in the number of cases. We see a return more to kids back in school, and a lot of the pain and suffering starts to diminish. I mean, these are things I dream about at night, and it's our hope that that will begin to happen in the here as we move deeper into the spring and beyond. That is sincerely our hope, and it has everything to do with I think vaccine acceptance rates, which we hope will continue to rise as the public sees that the rate of adverse events and side effects is low.
Thank you. And of course, that's what we are all wanting to see. I guess just to wrap up that question is that because we're targeting the most vulnerable, because we know that 87% of the deaths that we see are coming from our nursing homes and our most vulnerable, shouldn't we see that death rate drop, I would say, in the next couple of weeks once they've had the first dosage, which gives them some protection, and then the final dosage?
I'd like to defer to Dr. Watts to offer her thoughts on that if I can.
Thank you. You know, I think it's a great question, and I think we're all very hopeful that we're going to see what you're describing, but truthfully, we don't know yet. And the reality is, you know, the vaccine is still coming out slowly, right? So we're moving through the nursing homes, but we do know that it does take a little time to get immunity, and that we also still have really high community spread. And I don't, you know, I'm happy to spend most of my time thinking about the vaccine right now, but the reality is we still have a lot of sick patients in hospitals and a lot of community spread going on. So at what point that vaccine distribution and getting out there and getting the immunity in folks sort of crosses that line of epidemiology, we hope it'll be sooner than later, but you know, we're all flying a little blind here. It really is going to be watching how things go next.
Okay.
Okay, thank you. Terry, and I don't know if the doctors can help, but I think this would be more of a question for you. I was researching this a little bit to try and catch up. As of today, CBS News states that through the CDC of January 13th, the percentage of vaccines that have been distributed through the states that have been actually used is in Ohio, which is about the mid-range state, is 34%. Does that mean there's 66% of the vaccine still within the state to be distributed, which is the way I read this?
Well, I think that's a good question, Councilman. I know that we've had some variability in the speed at which vaccine has been distributed. I know that a huge distribution is now happening statewide, and so the recent release of vaccine across the state, I think 100,000 doses just began now. Folks would have gotten that vaccine, but they've just begun vaccinating those 80 and above. So some of that, I think there's a bit of a lag in some cases. I think, we can do better with a turnaround of vaccine. The governor has said if you get it, he wants you to use it within a week. And certainly that's a good measure for people. We are beginning already our second dose vaccinations for those. I think the hospitals have already begun that process, and we are beginning ours next week for the doses we started with EMS at the end of December. So we continue to do our best. I think there's some variability that exists around systems and entities to move vaccine quickly. In some cases, people are building up capacity to do so. And I think that is kind of my short answer. We could do better. And I know that people are beginning to ramp up with greater speed.
I'm not really concerned. And again, I'm not trying to pick on anybody, but it seems to me that if there's 66% of the vax that were sent from the feds to the state of Ohio, it certainly isn't us dragging our feet. It would then equal the state dragging their feet. And if that is true, then that would be a concern I would ask you to raise with the governor. And if it is true, I'm appalled at that, considering that our infrastructure seems to be ready to go, seems to be out there. The candidates that want it are waiting in line. And if true, I don't know, but if true, that 2/3 of the vaccines sent from the feds to the state haven't been distributed yet, I've got a real problem with that. So I would ask you to pursue that. And that may not be true. I mean, this is, a CBS News report, so I don't know. but if you could find that out. But if it is true, I think that bodes well. If there is more vaccine coming through the federal government, is there any indication that the suppliers are readily supplying the federal government with these doses? Or is it your understanding we're out of them?
So it would be my understanding that the rate at which we're receiving them, we had originally thought that there was a stockpile of vaccine that was at the federal level being held back, presumably sort of second dose stockpile, that they were going to be freeing up those additional doses to get them in arms. And the reports we are now hearing from the state is that indeed that those doses are not available, that they had been released. So we're hearing that the current flow of vaccine in this 100,000 range statewide is what we can expect, in that range in the coming weeks, each week. And so that's my understanding is that's the flow that will then, after a few weeks, will start to increase. But I don't have good vision beyond that. And I don't think anybody does at this stage.
Right. Something seems askew. I thought the original purchase was 100 million, which if spread out equally per state, we'd be sitting in a pretty good spot. If that's not true, obviously there's a screw up somewhere. And again, I just want to deal with what's on our plate today. But if you could pursue that for us, that would be very helpful, I would think. Are there any further questions for anyone on the panel?
If I may follow up with that, Chair, I read also that there are doses that are being held in our own nursing homes ready for the second vaccine. Are we holding back in nursing homes ready to administer that second? And could perhaps those be counted as what's being held?
That's certainly possible, Councilwoman Baker. Most of the nursing homes across the state, actually across the nation, signed on to the federal pharmacy program. So locally, pharmacies like CVS and Walgreens are actually doing most of the vaccinations in those nursing homes. And so they would have would be the purveyor of that information. But I know that it's certainly possible that could be a salient point in this discussion.
Yeah.
Interesting. Anything further?
Actually, I do, Mr. Chairman.
Yes, sir.
I think what I just heard you say, Terry, is that the vaccinations take place at CVS and other pharmacies, but not necessarily in application to the nursing homes. It's not happening at the nursing homes. Is that accurate?
Councilman Jones, actually, they are going into the nursing homes and providing those vaccinations. Okay. They go out, they have a contract, they show up on site, and they take care of the residents and the staff there. Yes.
That show. Okay. All right. Thank you.
Okay. And I've heard, when I heard those reports and found out those were true, it was an amazing thing that they got done. It was just really important to get those folks done. Anyhow, thank you very much for the information. Doctors, thank you for your time. We greatly appreciate not only your time, but your efforts during these very trying times. We look forward to providing Terry and his group anything that they may need. I know the executive's going to talk to the council president regarding possibly some of what we talked about here today. To really, I think it's very important to get something in the hands of seniors in their homes so they can read it for themselves. I just think it's a psychological and important thing for them to have. Anyhow, thank you very much, everyone, for participating, and we will proceed with item C, Resolution 2021-0001.
Ordinance number 2021-0001, enacting section 208.04 of the Cuyahoga County Code to establish a Cuyahoga County Diversion Board to serve as a resource for information and advice on operation of and to provide recommendations and input goals, strategies, and programs of the Cuyahoga County Assessment and Diversion Center.
Good afternoon, Councilman and Council. Brandy Carney, Chief of Special Operations for the county.
Hi, Brandy. How
How
are
are
you?
you? Happy New Year, all.
Once again, also before you start, we have a proposed substitute.
Mr. Chairman, if you're happy, I can take a stab at explaining what's going on here. There's actually a.
Yeah, I'm going to give you 3 hours to explain this one. What happened?
Well, I think the first one I submitted just toward the end of the year would fall into that category of not quite ready. And then when I took a closer look at it, when I got back after the holidays, I realized there were a couple of problems with it. So I tried to tackle several things here. One is probably the fact that I'm struggling to count to 5 in a couple of situations. It didn't. All the members are serving staggered terms, so it didn't really identify all of the appointees by the executive, how long the initials would each be serving. And then also it wanted to clear up the fact that it's a total of all of the entire 7 members who would be serving on the committee, that no more than 2 of those could be county employees. The initial version are read as though that could be interpreted as though that only applied to the 2 appointees of the council president. That wasn't supposed to be the case. Then I think it's made a little bit easier to read by breaking out 2 different paragraphs for the appointees by the executive and by the council president. Then in discussions with council staff, I think primarily Brendan realized there's a couple things to throw in here to make it better. And that's what the new paragraph A2 is in there, talking about initial appointees not being prohibited from continuing to serve if they're reappointed, and also describing how vacancies are filled. And then down in paragraph B, we wanted to make it clear. Well, let me take a step back. Up in paragraph A1A, there was a provision that said one of the chair had to be an appointee of the executive. That was stricken, that was taken out. But then down in paragraph 8, or B rather, we added a provision at the request of the administration that the chair, whoever the chair is, would serve for a total of 3 years, just for purposes of continuity over the life of this board. So those are the big things here. It's our custom in the code when we identify numbers to use both text and digits. So I went back and cleaned that up as well. So I tried to make it easier to understand, believe it or not.
I don't know if that was mission accomplished, but I after reading and rereading and listening to you, it makes a little bit more sense. Again, I just wish we would take our time with these. We weren't in a hurry. We're not in a hurry. I know the importance of this, and it is important, and that this committee will be doing some of the more important work in the near future as we move forward with this project. So having said that, are there any questions or concerns from the committee regarding the substitution? Okay, hearing none. I would like.
Clear, I'm sorry to interrupt, but just to be clear, we're voting on, you're considering the substitution that was submitted later this morning, correct?
It's I got it this morning, so
Hi, Mr. Chair, this is Janine. Yes, Greg, that's the one that you submitted this morning.
Okay.
Is there another one we should be concerned about?
Yeah, Mr.
There was
Chair.
one that was presented in the agenda, and there was one I had to send in this morning with, again, like I said, I'm having trouble counting to 5 for some reason.
Okay. Well, I believe this is it, and I'm going to go on I got this morning, so I'm assuming this is it. And as you talked, I followed you, and it seems what you were saying is in the document. Yvonne, is there a concern?
Yeah, I just want to make sure that I have the right one. So it'll be a total of 7 members on this board. Is that what the proposed substitute?
Correct.
Yes, and the way you can tell is if you're looking at A1A on page 2 of the ordinance, It says
Yes.
two of the five appointed by the executive shall serve a term of 4 years, 2 an initial term of 3 years, and 1 an initial term of 2 years.
Okay, yes, I think I have the right one.
Okay,
Okay, are we comfortable?
thank you. Again, apologies.
That's fine. Yvonne, are we okay?
I'm okay, thanks.
Okay. I will propose that we substitute ordinance 2021-0001 with the proposed substitute we received this morning. Do I have a second?
Second, Conwell.
Any further discussion regarding this? All in favor? Aye.
Aye. Aye.
Against? Okay. We'll move forward with the the document as ordinance 2021-0001 as substituted. Is there anything further from the administration regarding this? Ms. Carney?
For the sake of brevity, I'm happy to answer any questions. As you guys know, the diversion board, we're really excited to get it started. We've said all along, we want to make sure that we have a board to support the Diversion Center, to serve as a resource for information and advice, assist with goals and strategies of the Diversion Center itself. As in the resolution, it identifies 7 members, 2 to be chosen by council president, 5 to be chosen by the county executive. It's imperative that we are representative of the entire county and diversity within the county, as far as the 7 members that are selected, so that we really have a great diverse group to charge on this board moving forward. And then I would just add that the reason for the terms being up to 4 years is, especially being a new board, we really wanted to ensure continuity, that there wasn't significant and quick turnover within the board members itself. So particularly with the beginning of the Diversion Center getting up and running. So our intention is to elect members for this board in March of this year. One of the first tasks would be putting together their own bylaws, as well as looking at some of the policies and procedures and operation of the Diversion Center. So within the ordinance, it identifies some of the initial duties that are tasked with the board. I can answer any questions if you have any.
Any further questions?
I don't have any questions in particular to that specifically, Mr. Chair. This is Conwell. But I did put a proposal into President Jones in regards to, for the health and safety and well-being of the county residents. I was looking at, for the 2 appointments for council, to be the public safety chair and the health chair. That was my suggestion, but looking at the terms, I don't know if for the remaining 2, if that would propose a problem. And I know President Jones is on, and I don't know what his thoughts are. He said he would get back to me, so
Yeah.
I just want.
I think the purpose of the board is to have community members outside the elected realm of the county. I would anticipate that if the executive or the council president wanted to recommend one of their appointees to be, say, a mayor or a council person somewhere else, I would anticipate that would be fine. But I think the spirit of the legislation is to have the general population pretty much be this committee that would control as their direction.
And Councilman, can I add?
Yeah, thank you.
In the legislation we did, as you said, we want a mix of county staff as well as community partners, really, so that there's diverse engagement in this board. And within the resolution in front of you, it does say, in total, not more than 2 members would be staff of Cuyahoga County. So that includes for the entire 7 members, not more than 2. So it could be 0, could be 1 or 2, but not more than 2 would be Cuyahoga County staff members.
Yeah, and thank you, Mike and Carney. So Yvonne, it's true. This is a committee board, a community board. So it is different than our council. We still, as the council, hold that legislative power that we have. And this is an advisory board, and it is community based. So we will be looking towards community members. I don't want to use both positions for council members again, council members. It is community based. So I will be looking for, again, to fill in that spirit when I feel it.
Okay. Yes, ma'am. Go ahead.
We can talk offline. Thanks.
Yeah, and we can. We just have not had a chance to talk, Yvonne. And Councilwoman, we will talk.
I understand where you were going with that when I read it. So it could be construed the other way with the 2 potential appointments being from the executive side of it, not necessarily the council side of it. But I think we're comfortable as we stand, correct?
And I am comfortable with it the way it stands, Councilman Gallagher.
Okay. Well, hearing no further comment, any further comment? I would propose to move ordinance 2021-0001 as substituted to the full council for second reading. Do I have a second?
Second.
All those in favor? Aye.
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 That's on its way to the council of the whole, and a project that we're going to keep an eye on. And I would be remiss if I didn't thank all those that participated, Brandy and your team, the sheriff, his team, the legal department, the prosecutor, the judges, the council, the executive team. It was truly a collaboration of everybody. Sometimes we needed to be prodded, but prodded we were in the right direction. And it's hopefully something that will help not just those individuals that will go through the progress or the program, but will help the county in our bottom line, which is always an important thing when dealing with the jail and services provided there. So once again, congratulations to everybody. Thank you to everybody that did participate in this. And again, going forward, I can only anticipate the Cuyahoga County Council would be 100% behind helping in any way we can. Finally, on discussion B, we're getting close to our time, is 2020-677. Who's here to discuss that?
Rhonda Gibson and Bob Corey.
Hey, Bob.
In that order, Mr. Chairman.
Okay. Maybe Bob, you can help us first. What are we doing here? What's the necessity of this?
So I'll let, go ahead, Rhonda. You're going to do the details. Go ahead.
I'm sorry, go ahead.
Sure. Rhonda Gibson, Administrator of Corrections for the Sheriff's Department. As we all know, COVID has had a presence within the correction centers since approximately April. And as a result, we all know that the number of inmates went down considerably so that we could try to tackle COVID inside the jail. When we did that, most of the quote unquote less risk inmates were released from custody. Those are the specific type of inmates who would be housed at Bedford Heights facility. Bedford Heights facility is designed to only house minimum or a low medium classification of inmates. Bedford Heights also is rated capacity of 116 beds. 100 of those are dorm style beds, which do not give us the capability to isolate and separate inmates from a possible COVID exposure. As the number of inmates went down, the number of inmates at Bedford Heights went down. We found ourselves at times with more staff than inmates at that jail. We therefore made the decision to reduce the staffing there. We pulled back and the number of inmates continued to go down. At that time, we then entered into a discussion with Bedford Heights to discuss pulling all inmates back to the downtown correction center because of staffing concerns downtown. Not only were inmates being affected by COVID, but also staff were as well. So we needed those additional staff members at the downtown facility. At that time, speaking with Bedford Heights, they understood our predicament, and we came to a compromise where all inmates would be housed downtown and Bedford Heights would therefore do the transportation for a monthly fee. The monthly fee is $4,000 a month. And while that may seem steep, the significance of that is that we no longer have to have any staff at Bedford Heights. It also eliminated the Sheriff's Department from having to transport from Bedford Heights to the downtown facility. $4,000 was an amount that we agreed upon, and Bedford Heights agreed to that as well. So that's where we are.
If I could, Mr. Chairman, if I could just add one thing contractually. The reason why we agreed to pay Bedford Heights anything, was because under the November 29, 2017 contract, we were required to provide them a facility to house their inmates. So they had no obligation, and they stood on that they had no obligation to transport inmates to another facility, that is the downtown facility. So they had us over a barrel in that respect, contractually. So we had to provide them a financial incentive to transport their inmates directly to our facility, which, as Rhonda pointed out, obviates the need to have any of our staff wasted at that correctional facility and eliminates the need for our sheriff's deputies to have to be out there just to transport inmates from the Bedford location. So what was happening prior to this agreement is we no longer, wanted to have staff out there, but we had to send sheriff's deputies and had to have minimal staff there to receive Bedford Heights inmates, go pick them up and bring them to our facility. It was, as Ron said, far more expensive than the $4,000 a month required by Bedford to pay them to transport our inmates. The $4,000 was, they came up with and showed us some numbers that would basically cover a full-time equivalent patrol officer to be on duty to make those transports.
When are we out of this contract with Bedford? And do we have
10 years.
Do we have an
Now,
out?
here's the thing, Mr. Chairman, 10 years, there's a 6-month out, right? We could have exercised that 6-month out clause. But here's the thing, we don't know what the future is going to hold post-COVID in terms of the jail population. And I can't look you in the eye and say, we're going to stay at below 1,400. Because I know, and I'm loath to use words like artificial, Trevor. I'm loath to say that we're going to be able to maintain some of the processes that we have in place, like exceedingly low bonds, grand juries reduced by County Prosecutor Mike O'Malley, bail arraignments suspended in some cases. And so what is the jail population going to look like post-COVID? Time will tell, but to say that we should terminate the Bedford Heights contract and that we don't need it any longer for overflow for these low-level felons, I cannot tell you that. So we did not and don't recommend at this point terminating the contract. We have the jail currently in a stasis of suspension right now where they're maintaining it And if we need it, it's available and it's not costing us anything. It's mothballed right now.
Well, I appreciate that. You know, to juxtapose the Bedford with Euclid, we basically had Euclid over a barrel. And what we did was we did them a great favor and helped them out. So I don't like doing business with anybody that's got me over a barrel and whacks me in the head with the contract, even though I understand it, you know, we went in with eyes wide open, and there, as Bob, you probably are now aware, there's a backstory to all of this that is unfortunate. Here's where I'm at. And I don't see time is of the essence with this right now, because we don't have a sheriff. I want to be able to talk to the sheriff, let that person look at this, and then come back to us after he's discussed it with you. And I would anticipate discussion with our leadership team as to what we want to do going forward. The magic 1,400 number, you know, I've not been shy in telling you where the problem is, and that problem is still there. We saw what we could do when the media and the newspapers shine a light on the jail, and when that light gets turned off, that number shoots back up to over 1,500, and now higher than that. So that's, in my opinion, that's manageable. And if we have to be that shining light, so be it. That's for another day. But as far as moving on this, I really would like to wait for the eyes of the new sheriff, because that person's going to end up dealing with this anyhow. What does anybody else think about this?
Mr. Chairman?
Mr. Jones?
Yeah. Mr. Curry, when you made the comment, you can't guarantee that it will not rise above 1,400. Well, I know you certainly cannot guarantee. This is a collaborative effort between all the parts of the criminal justice system. But that thought process is just not something, I just don't see that as acceptable. It's not acceptable. As the councilman has said, light was shined on this criminal justice system, on this county jail, and the numbers were brought down under 1,000 at one point. And it was because of COVID. Hey, we have to know what was done, and we need to make an effort, the entire criminal justice system, to try to keep these numbers down. Because even at 1,400, that means someone is doubling up within the facility. I don't remember the exact number, but there was a number where, and again in light of COVID, where you are now bringing more individuals. They're not each individually isolated. So it's a challenge even at 1,400. So I just put out a challenge to all of us that we find ways. Well, I won't even say find ways. We've seen it. It's been done. We were brought under 1,000, and what was done needs to be shined on that and commended for what they've done, and work hard to replicate it and sustain it, make it sustainable. Because to go back to what we were, I don't think it's acceptable. We need to find ways to keep this jail population at manageable levels. And this environment of tough on crime is a long gone dinosaur. It's a dinosaur that has a track record of 50 years of not being effective. And we need everyone to all hands on deck to find ways collectively to make sure we can keep this jail population from exploding. So I'll just leave it at that.
Chairman, if I ask a question? Nan Baker.
I'm sorry, go ahead.
Thank you. I wasn't sure if I was on mute. How does the diversion center play into this? 50 beds turning every, I don't know, week or so, and then being sent to another place where more help can be given. That was supposed to try and help those that shouldn't have been in jail to begin with, and try to give them the help they need to get off whatever addictions or diagnosing mental illness. So how does the diversion center play into the numbers?
It's going to play in greatly in that some of these folks we're hoping will qualify under the diversion program. They'll never walk inside the jail unless they go back on an agreement that they're going to have to sign and then be subject to legal proceedings. When up and running, that's going to be a fabulous thing. If it's done correctly, it's going to be beyond fabulous. That's an important time. Bob, do we have a scheduled date? And I'm not asking you for a solid, concrete time, but do we have an idea when the diversion center will be up and running?
I did as of yesterday. Mike Dever gave it to me. It was pretty aggressive. It was, I'll confirm with an email, but I think it was before summer.
Okay, so
that the temper with using Oriana House,
right,
as a basis to do it. Yeah, putting the permanent solution off, but nevertheless, the beds are available. The program should be available and soon. So it's full steam ahead. And to add to that, as soon as I get off this call, I'll be jumping on a central booking meeting, another infrastructure and process improvement that will further help with bed reductions, jail day stay reductions.
Yeah, I was going to go there next with the building of the new jail. So things are in the pipeline, Nan. This is a good first step, and it will be reflected in those numbers downtown. The central booking, again, I would anticipate done right, up and running, doing what it should be doing. In the end, will reflect in those numbers downtown in a positive manner for us as far as our bottom line. And I think most importantly is the building of the new jail, which I got to tell you, I don't understand why we're not digging dirt today, but COVID did have a bit of a delay to us. So I would hope sometime this summer we'll be announcing where this jail is going to be and when we can anticipate it opening up. And it's probably minimally a 2-year build out. Once that's done, then we're really rolling in a positive direction towards possibly a justice center, and then the whole ball of wax falls into place as the gears are running with one another. So we have a lot of balls up in the air right now, but they're all being juggled in a really good forward motion. And every incremental step that we take with things like the building in the new jail and diversion center are very positive for our bottom line. So I'm very happy with that. And all of us want to move faster than than's possible. I mean, that's human nature, but I think it's a real positive, and I think we have great things to look forward to. But if everybody's comfortable, I would like to kick this discussion to after the new sheriff is seated, and then go back and talk about this with the new sheriff, and to get a consensus moving forward, what we should be looking at doing. And that's what I think. What does the committee believe?
Mr. Chair?
Yes, ma'am.
Mr. Chair, I agree that it's important to have the new sheriff to take a look at this, but I think it's important to understand that I agree with Bob Corey that we don't know what's going to happen post-COVID. And I know all these things are going to come together in the next couple of years, but indictments have been down at least by 40%, 50%. Grand juries haven't met because of COVID. So we're really operating on I believe, an unrealistic basis to project out that this is how it's always going to be. And that's why the numbers are in great part down, is just simply because there's no indictments. And eventually that's going to happen. And we've got to be ready to deal with that until we can get diversion up and going, until we can get the new jail and justice center and central booking in place. So I think we need that backstop.
And as of right now, we do. I just don't, I really don't want to lock in till 2027 with the new sheriff that may not agree with this. I would anticipate and I would speculate that the new sheriff would agree with this, but I don't know that. We were going to complicate things further. We were going to have our, well, I guess it would have been a preliminary discussion on confirming the sheriff Thursday. That's going to be canceled because necessary paperwork wasn't delivered on time once again, potentially because of the mail and COVID. So that's catching up with us everywhere we turn around. But I think what we can do is within the next 2 weeks, have the sheriff on board. And I don't believe a 2-week timeline to revisit this with the new sheriff seated is something that we can't do, and it's going to harm us. So that's what I think. Mr. Jones, where are you at? Mr. Curry, did you have something to say?
Yes, sir. Just in case we failed to clarify, I agree with you 100% that when the new sheriff gets on board, we take the early opportunity to look at all of our jail contracts together with the executive, chief of staff, jail administration, and say, look at all of them, including Bracknell, Euclid, Highland Hills, Metro Parks, Richmond Heights, Woodmere. And in terms of how we want to be, whether we want to be, quote unquote, in the external jail business, do we want to continue to contract with municipalities to accept inmates? What is the jail population going to look like post-COVID, post-diversion, post-central booking? And then make determinations long-term about these contracts, including the 800-pound gorilla contract in the room, the City of Cleveland contract. This contract, this what we're looking for, this narrow amendment to the Bedford contract, is just a temporary contract because we have suspended operations in Bedford, but we still have to get, and we pulled back all our corrections staff. So to the benefit of the jail downtown, because we've got experienced correction officers out there. We have a need of correction officers. Heck, we've got the National Guard there to help replace COVID-stricken correction officers. So pulling the staff back was a boon to downtown county, and we don't need the Bedford Heights jail, but we're obligated to take the Bedford inmates and transport them to our facility. And that costs Bedford. I probably shouldn't have said, oh, they had us over a barrel. They're saying, look, we had a contract with you to drop our inmates off at Bedford. You want to mothball Bedford? Fine. Here's our cost, $4,000 to transport. We're going to ask you to bear that cost. But as you'll see in this contract, it is a temporary contract just until, and we can end it anytime we no longer need them to transport inmates. So this thing that we're putting forward is just a temporary amendment to the Bedford contract. When the sheriff gets on board, we should all make the determination whether we need the contract at all and exercise our 6-month clause to terminate the contract in its entirety.
Okay. Well, we don't have legislation in front of us anyhow, so there's really,
okay. Oh, okay.
I mean, this, we haven't posted it.
I see.
This was just a discussion item. So it probably works to our favor that I would imagine we can meet in 2 weeks. I would hope, I don't know, but maybe the sheriff's seated by then, and then we can move forward. Again, like I said, I can only assume he'll agree with this, but I don't want to speak for him. That's just where I'm at. I mean, we don't have anything to move on anyhow. That understood? Okay. Anything further regarding this item? which I would anticipate we'll be revisiting in legislative form at our next meeting, which would be in 2 weeks. Okay, great. Listen, this was kind of a long meeting. Sorry for the newbies. We don't usually do that. We try and watch our time, but there were some important items, obviously, that we had to deal with. Again, the sheriff's confirmation will not go forward Thursday. We did not receive the necessary documentation through no fault of anyone, but the system itself has cost us some time there. My anticipation was when we do receive that, we can set the confirmation hearing, and hopefully it'll be before our 2-week meeting. Give that sheriff, if we agree to moving forward, if we can confirm them and get them on board, we'll do that. And we'll have this, Bob, in legislative form, I would imagine, for the next committee meeting.
Thank you,
Fair
sir.
enough. Anything else? Anything further? Thank you, everybody. We're adjourned.